infected non-union, the case series. So the junctional area of the proximal TBR is always a tricky one. It has a very poor blood supply. The skin, the bone is very subcutaneous. There is a flexor pull on the distal fragment and extensor pull on the proximal fragment. Thus, the reduction of these fractures is very difficult, and it can lead to non-unions, and especially if there is septic non-union, then it results in knee stiffness, discharging sinuses, and limb length discrepancies. So in my study, I have included 25 patients, and it is a 10-year study from 2010 to 2020. Patients have presented to me from around 3 months to 6 years in various timings. I have excluded intra-articular non-unions and unfit cases. So out of the 25 cases, 6 patients did have an infected gap non-union, 7 patients had non-healing ulcers or wounds on the bone fragments, with protruding bone fragments, and 1 patient had a deformity of 20 degree of varus. Out of all these 25 patients, most of the patients presented with an internal plate in situ, some presented with an internal interlock nail and external fixator, while 1 patient had fixation done with K wires for almost 4 months. So in the procedure, I start with fibulectomy because it is a clean site. So after doing the fibulectomy, I suture off the site so that there is no infection to the fibula. Then I open the non-union site. I debride it thoroughly, do the sequestrectomy and collect sample for culture. This is a deep tissue sample. Excise the bone to remove this necrotic bone and for better contact. Align the fracture fragments and try docking if the pulse allows to do so. And then a hybrid Elizero ring fixator is applied. Post-operatively, as we know, we do the regular dressings and pain management is done. Rigorous physiotherapy and weight bearing is as per the patient tolerates. On follow-up, I check all the pin sites, inject gentamicin if there is minor pin tract infection, and check the Shanspin wire tension and Shanspin loosening. I check the callus after 2 months. If there is callus, I continue with my treatment and dynamize the rings just 3 weeks to 1 month before the removal. But if there is no callus, then I start with an accordion maneuver. Depending upon the callus formation, accordion maneuvers can be given either once or twice, and then proceed with the treatment. Of all the 25 patients, everyone had their infection eradicated. 21 patients did achieve union. For 10 cases, we had to use accordion maneuver to achieve union. When 10 cases, gradual compression was enough. In 3 cases we used bone transport, and 6 cases the plastic surgeon did a gastrosoleus flap. The average fixator time was 7 months, and the Asami score was excellent for 56% cases. We had certain complications like fracture at the pin site, discharging sinuses, refracture, and limb length discrepancy, and they were all taken care of. So I would like to suggest that Elizero ring fixator is a very good modality for this junctional area of the proximal tibia because it has multi-level, multiplanar and multi-directional stability. We can use compression, distraction, accordion maneuvers, dynamization and bone transport, which will help us in union, and it shortens the length of treatment. Infection burns in the fire of the regenerate, and so infection is eradicated. Plastic surgery is very well possible with the fixator on. This is my first case of a 48-year-old male. He had pain and discharging wounds all over the tibia, and he was operated elsewhere for a number of times before he came to us. So in this case, he had a external fixator tube on his tibia. I removed all the implants, freshened the fracture site, and put a 3-ring Elizero construct. The proximal ring has a drop fixation of an olive wire to aid in the alignment and reduction. He needed 2 cycles of accordion to get his union good, and now this is the 2-year follow-up where he has good range of motion, but he has 2 centimeters of shortening and he does not want any lengthening procedures. He is fine with a shoe raise. This is another case where This junctional area was treated with the external plate as an external fixator, and he also had discharging sinuses. So I went in and removed all the removed all the necrotic material, debrided the soft tissues, and put an Elizaro ring fixator. This is after the fibulectomy, of course, and his soft tissues healed very well. And 9 months later, his Elizaro ring fixator was removed, and this is his walking video right now. He has a small sinus for which we are debriding. This is a third case of a very young boy, and he had a ghastly injury by which he had lost his left leg. And here he already had an Elizaro fixator on. So
Dr. Madhura, please complete your talk.
Yes. So we did revision of the Elizaro fixator, and this is his result. So I would like to summarize that Elizaro can take care of infection, non-union, poor vascularity, deformity, and shortening. So it's worth it. Thank you.
Very good presentation and very good cases you have seen. One question, please, short question. Are you doing Catagni technique for ring frame fixation or Elizaro technique? What
Catagni
Catagni?
Yes, sir.
Why?
Sir, it is easier.
Easy.
Yes, sir.
Okay.
It helps a lot in time.
Okay.
And after reduction, I fixed the fragments with two provisional K wires and passed the frame.
Okay.
Then the time is also saved, and it is easier, sir.
Okay. How you plan for a day before surgery? You make a ring, or on table itself you make a ring?
On the table,
are you preferring to do X-ray with ring before doing operation, or just?
No, sir. I start preparing the ring while the patient is being induced, and then just check the rings before I start my surgery. But after the sequestrectomy and debridement, sometimes the dimensions of the threaded rods do change. But that is okay, that we can modify on table as well, sir.
In how many cases you have changed the whole assembly in full length of the treatment? Are you doing complete treatment with same frame which you have started in first day one? Or you change in wire and ring frame? Are you, if you takes 9 months for a Elizaro frame, so do you prefer to change the frame? Or you continue with that only?
Sir, in many cases where the treatment duration was long and if there was some pin loosening or wire loosening, we have just changed those wires or those shanks pin, but the entire frame remains the same. And if we wanted to do a corticotomy, then we have added a ring. But other than that, we have not changed the frame structure as such, just exchanged wires.
Okay, thank you. Nice. Now.
Good afternoon, everybody. My topic is neuropathic foot and ankle treatment with Elizaro fixator. So, neuropathic ankle and foot is a potentially limb-threatening disorder. Increased incidence in persons with long-standing diabetes, concomitant peripheral sensory neuropathy, and main problems encountered in this process are osteopenia, fragmentation of the bones, joint subluxation, dislocation, ulceration, and development of deep sepsis and osteomyelitis. There will be some granulation tissue, necrotic tissue, damaging the joint cartilages. The most proposed etiologies are dysregulated autonomic nervous system with hyperemia. Other one is loss of peripheral sensation, proprioception, repetitive trauma. There is inflammatory resorption of the traumatized bone. Procedure involves thorough preoperative planning, workup, and procedure. There is skin incisions along the bones. Then sometimes the ankle joint, lateral approach, and the procedure involves zero frame application with 1 or 2 rings at the tibia, 1/2 ring at the heel, and 1/2 ring at the metatarsal area, and the calcaneal tibial Y. Post-operative will be wound care and there will be two compression 1 or 2 times a week for 6 weeks. And calcaneal tibial wear will be removed around 2 to 3 weeks and allow weight bearing and follow up for regular clinical and periological review. Okay, first case is a 58-year male patient on diabetes. He had a mild rheumatoid arthritis positive. First, initially left side there was some charcoal foot for which we did ESO. He was fine. For the second time, he went to some other doctor. They had done nailing and arthrodesis, but they got failed with the breakage of the implants. Then he came back to us and we removed the nail and the loose screws and we retained the distal fibular screw for the stability. We did elysial fixator and removal of the cartilage, soft tissue, infected necrotic tissues and fixed the brain. So calcaneal tibial wire removed at 2 to 3 weeks and allowed him weight bearing and walking. This is the post-operative pictures with adequate arthrodesis, and this is walking at 2 years follow-up. Second case is 58-year female. She has a kidney disease. We came with swelling, deformity, and instability. In our country, they have advised amputation. She did not amputation, and we have done through all-year approach. We removed the infected bones, alectomy. Then we did laser fixation with carbon frame rings. This is the post-operative. The carbon frame ring allowed us to assess the fusion little better way, and she got the union. And around 5 months, she's walking like this. We gave one foot splint and AFO for initial support. Other case is 57-year-old lady. She had came in instability with difficulty in walking, diabetes. We did through all years approach. We did alectomy and fusion. This is the post-operative after removal thorough stability at the ankle. Other case, 74-year male came with severe soft tissue defect, swellings, discharging sinus, osteomyelitis, and heel wound. We extensively opened and debrided the soft tissue and alectomy done and ankle and ankle and midfoot fusion done. The heel wound has healed completely and adequate arthrodesis has come. Other cases, 58-year male diabetic. He works in ice factory and he developed neuropathic ankle with swelling. And he had lateral malleus ulcer. They had repeated debridements which did not heal and got into neuropathy. So we did same way. We did talectomy and ankle fusion, talectomy calcaneal fusion, and around 5 months fusion is good and removed the fixator. With the fixator we allowed him walking and he was happy. Another case is 60 years female. She has extensive destruction of the ankle with talus dislocated, necrotic. We removed the talus, removed the necrotic tissue and fixed the frame. And another case is 64-year female. She had a midfoot extensive granulation tissue damaging the midfoot and the subtalar joint. So we excised the infected tissue through the wounds first and also subtalar approach. We fixed the frame and she went on to progressing well. Union also achieved well. She was able to walk without any support also. Unfortunately, after 4 to 6 months, she fell down and got ulceration at the ankle joint, which led to cellulitis and she went for amputation, below knee amputation. Other cases, 66-year female with diabetic neuropathy. Same way, we did the arthrodesis and fusion well. She was happy. So, patients were able to wait their immediate post-operative period, awaited for 3 weeks when calcium tibial pin used. Around 4 to 5 months, once clinically and radiologically good union seen, fixated dynamized and allowed to walk freely, X-rays done for check X-rays. And we studied 20 patients. In that 2 patients had recurrence of skin ulcers, 1 patient had below knee amputation.
Conclude, please?
So, correctional stabilization of the foot and ankle deformities with lizard fixator are effective and allow correction of the deformities, avoiding the complications of internal fixation. Advantages are mainly weight bearing, unstable correction, and enables increased blood supply, which allows better healing and infection and better prevention of skin ulcerations and amputation avoidance. So, however, ejection fixation involves lengthy duration of treatment is commonly associated with tract infections. Thank you very much.
Okay, nice presentation, Daksha. Why you are doing tarectomy in so many cases?
Sir, the callus was on opening, callus was sclerotic,
Okay.
and there was some breakdown of the cartilage
Okay.
and also necrotic tissue. And
So, do you prefer to shift the foot posteriorly or you kept in the same alignment?
we
Because
did
post-operative after healing,
yes,
walking is good if we translate foot little posteriorly.
yes, sir.
Huh?
Yes.
So, are you? But you are not shifting in any case.
Yeah, no, so we exercise some of the calcaneal posterior process and
Okay.
we get the adequate alignment during surgery.
Okay.
And we use callus as bone graft if the callus is found good.
Okay. Nice. Thank you, Raj.
Thank you.
Now,
Good afternoon, everyone. My name is Akshay Kumar. I am from Calicut Medical College. I am going to present a talk on an unusual presentation of lower limb deformity in a young girl treated using the principles of deformity correction. So, coming to introduction, the metabolic bone disorders are the heterogeneous group of disorders characterized by the abnormalities in the calcium metabolism or the cell physiology. These disorders resulted in the generalized decrease or increase in the bone mass and increase in the ratio of the organic fraction to the mineralized fraction. So these disorders are mainly characterized by the generalized bone pain, enlargement of the metaphyseal segments, knock knee, both tibia as in the rickets, and sacral tibia in the Paget's disease. They usually present with the multiplanar bony deformities which are prone to fracture easily. They are usually resistant to conservative line of management. So before proceeding with any surgical line of management, treat the underlying cause of the bony pathology and then proceed with the surgical management. So this is a case which I am going to speak about now. This patient is a 18-year-old female which presented to us with the multiple deformities of the lower limb and severe pain in the knee and other bones since 8 years. So the patient has a previous history of renal tubular acidosis type 1 and history of calcific pancreatitis, distal RTA and proximal myopathy 5 years back. The patient also had history of recurrent abdominal pain for 5 years. Now she presented with the proximal myopathy and the thigh pain and the knee pain. So the patient also had the history of femur fracture which was fixed. So but later it resulted in the valgus and the procurvatum on one side of femur. So later again the corrective osteotomy was done from the outside hospital and which again resulted in the varus. So when the patient came to us, we assessed the patient full length X-ray and we found to have the both femur varus and both bilateral tibia had the valgus deformity. So coming to treatment goals, the main treatment goals will be to find the cause of pain and deformity, to evaluate the old problems and to assess the deformity and planning of the corrective osteotomy. So when we did the investigations on this patient, we found diagnosed to have the patient was having hyperparathyroidism because of the parathyroid adenoma. So coming to management, so then initially we proceeded with the patient was proceeded to have excision of the parathyroid adenoma. Later, we tried to improve the bone quality, and then the deformity correction was planned. So, following the excision of the parathyroid adenoma, the pain completely subsided after the 1 year of. After 1 year of that, we planned for the deformity correction. So, coming to deformity assessment, we calculated the mechanical axis deviation. It was 8 centimeter on the right side, and it was 2 centimeter on the left side. And femur mechanical axis planning was done, and anatomical lateral distal femoral angle was found to be 127 degree, and anatomical axis planning was also done, where we found two coras over the affected femur. So one was having 22 degree and one was 24 degree. So and also tibial mechanical axis planning was done. And coming to X-ray analysis, so we found to have the patient found to have the varus deformity of both femur distally and proximally, and valgus deformity of both the tibia, and the limb length discrepancy was there over the left tibia. So coming to treatment of the deformity, so we planned in a stage manner. So first we planned for the varus deformity correction in the right femur. So and valgus deformity correction and LLD correction in the left tibia. So these are the main problems for the patient. And then, but patient was willing only to correct the right femur and the left tibia deformities. So there are available options for Elizaro, intermediate nailing and LRS. So we planned in this way. The first stage we corrected the varus deformity of the right femur by corrective osteotomy at the two levels with the IMSC nail. So second stage we corrected the valgus deformity and shortening of the left tibia with the Elizaro. So anatomical axis planning was done for the right femur and we found out the cora, and accordingly we did the osteotomy at the two levels, and then it was fixed with the intermediate nailing. So after 5 months we achieved this union, and also the clinical picture is shown. So this is the tibial deformity which was later planned to correct. So after the tibial deformity correction was done using the Elizaro with the corticotomy, and then the final result was this: the female took 5 months for the union, and the tibial deformity correction and the limb line discrepancy correction it took around 6 months of duration. She was not willing to correct the other deformities, so her functions were normal. She was relieved from pain also. So coming to discussion part, hyperthyroidism is a condition where there is increased bone resorption, and hence the bone will be more prone for the fractures, and deformities are more common among them. So difficulties do arise if the condition is unrecognized or if the patient experiences the mechanical compromise before the abnormality is detected. And for the deformity correction, we have to follow the principle of the deformity correction. We have to know about the malalignment test and the core identification, osteotomy rules, choice of fixation, whether external or internal, and the acute or gradual correction. So this is the take-home message. So in the metabolic bone disorder, the bone quality is very poor. So we have to correct the bone disorder and improve the bone quality before correction, and focus on the functional and anatomical compromises that the patient suffer as a result of metabolic disorders. Various methods are available, but whichever method is there, so you just follow the principle of the deformity correction. So gradual correction is better than the acute correction, the severe deformity and associated problems. Newer additives like SUV and X support eases the deformity correction surgeries. Thank you.
Dr. Akshay, you please continue your second paper also?
Yes,
You
yes.
wait.
I'll continue.
Okay, please start. You just name the topic and just start. Please start.
I'm about a newer minimally invasive technique using the external fixator for the management of calcaneal fractures, a case series. Introduction. Calcaneal fractures comprises 75% of all the fractures affecting the foot, seen commonly in the young adults, middle-aged group working in the labor-related fields. So coming to classification of calcaneal fractures, we all know the Sanders classification. And treatment methods, so there are various treatment methods literature suggests. One is open reduction with the plates and cancellous screws, SX low porosity method in the tongue type, and K-wires and the conservative type using the plaster cast. So, but ORIF has become the acceptable treatment modality, which is superior than the conservative management, supported by the numerous studies. But ORIF has to be delayed until the edema subsides. These are some of the disadvantages which the open reduction interfixation is having. So, and also the soft tissue healing should be complete until we start the ORIF, and post-operative complications like flap necrosis, wound adhesions, and hardware complications and infections are more common. So coming to external fixation, the advantage of the external fixator is that it can be applied on the day one of the injury, even with the significant edema and open fractures, and in the patients with the comorbidities like the PVD and diabetes. And we can start the patient on the early mobilization, and there is no worry of any flap necrosis or the wound adhesions. So coming to description of the calcaneal fixator, it has got 3 clamps: superior clamp, posterior clamp, and anterior clamp, and the central hinge. So there is 2 arms. One is a horizontal arm and one is a swiveling arm. And there is a varus valgus orientation of the posterior clamp. And also the external half of the pins can be converged into 15 degrees. It can be convergible up to 15 degrees. So application of the fixator. Coming to application of the fixator, before applying the fixator, we have to reduce the fracture. So simple fractures such as Sanders type 1 and type 2 without the much articular involvement, we can do the closed manual reduction and with the external manuals, and we can apply the external fixator. In the type 3 and type 4 fractures, we have to reduce initially, we have to use one K wire as a joystick, and we have to maintain the reduction, and we have to pass the second K wire in order to hold that reduction. So coming to application of the pins, after reducing the fracture, now we have to apply the pins. So the fixator is positioned according to the fracture pattern. So once the subtalar joint reduction is achieved, the first two pins are positioned in the subfrontal bone using the fixator as a template. So preliminary fixation of the fragments can be done with the K wires or the pin guides. So the second two pins are inserted at the level of the posterior apophysis of the calcaneus, and the third two pins at the level of the anterior calcaneal apophysis or in the cuboid. So these are the K-wire holes for the preliminary fixation of the external fixator, and this is how the fixator is placed. The first three inner half pins will be applied initially. So the fixator is positioned 15 to 20 mm away from the heel. So this is how the posterior pins can be oriented 15 degree. And after this, we have to lock the clamp, and we have to unlock the varus and the valgus hinge, and arrange the valgus and the varus deformity, correct it properly, and then lock it. So coming to after this, you have to go for the distraction. The main ray is separating the anterior and the posterior fragments and unlocking the comminuted fragments from the depressed area. Usually amount of distraction usually by 5 to 10 mm. The subtalar ray is distracted by 3 to 7 mm. Indications are mainly type 1 and type 2 Sanders fractures and open fractures in the patient with the multiple comorbidities. So radiological evaluation post external fixator, we have to take the axial view to look at the middle and the posterior facet joints, and also lateral X-ray to view the volar angle, descent angle, and costobatani angle. So this is a case illustration 1. So 20-year male fall from height, sustaining the Sanders type 2A closed fracture. The edema, the patient was having significant edema. So we proceeded to go with the external fixation, and this was the patient position. We positioned the patient laterally, and the intra reduction was achieved. It was, and then the external fixator was applied. So this was a pin application we did, and the immediate post-op X-ray was like this. So and the patient, after 3 months, we made the patient to come back, and we removed the external fixator and we took the X-ray, and we did the scoring with the AOFA's ankle behind foot score, and we got points of 85 points out of 100. So this is case number 2, 45-year male sustaining closed fracture parietal calcaneum. So one Sanders type 3AV and one is Sanders type 2A. We proceeded with the external fixator on the first day itself. So this was the intra-op pictures, and the post-op was like this, but the inferior pin was little bit outside of the bone, but we are able to achieve the reduction at the subtalar area, so it was fine. Then later, after 3 months, we removed the external fixator and took the X-ray, and the scoring was done, and it was found to have, the patient was found to have 87 out of 100 points of the AOFS. And this is a case illustration 3. It was also 39-year male, Sanders type 2B. There was significant edema, so we proceeded to apply the calcaneal fixator, and this was the positioning of the patient. We can also place the patient prone with the C-arm in that axial view, and we have to reduce it. This is a type of reduction we did. And then immediate post-op X-ray was like this, and the later post-op was done, and this patient follow-up has to be done. This is another case. So type 2A Sanders, pre-op, intra-op reduction fix, and post-operative. So this is also another case. So we have done this case. We have been following these patients. These 3 months has not been over. So the discussion is, the main goal of the treatment for the displaced calcaneal fracture should be restoration of the 3-dimensional structure with correct alignment in the coronal and the axial plane and height of the calcaneal body, rather than anatomical restoration of the congruency of the subtalar articular fragments. So the use of external fixator appear to achieve the same. So neither the subtalar mobility nor the clinical outcomes seem to be significantly affected by the obtaining the congruency of the subtalar facet. Conclusion. So the external fixator is an external surgical alternative for the complex articular fractures of calcaneus, obtaining the clinical and radiological results comparable to the other osteosynthesis technique and significantly reducing the soft tissue complications. These are my references. Thank you.
Nice presentation, Akshay. I have one doubt. If to be experienced surgeon is good, but for a beginner, if he is not able to reduce properly subtalar joint,
Yes.
then it's difficult to maintain the congruity of the subtalar joint later on.
Yes.
In Elizaro, usually we got ligamentotaxis also. If we put a frame in a proximal distal tibia.
Yes.
So I think in severely committed fracture, in early stage, we should go for that traditional or Elizaro technique or distraction technique.
Yes, sir.
It will be better. I think this is my just suggestion. It's a very good fixator when I have experience.
Yes, sir. Actually,
Yeah, you have done a nice number of cases. Okay, thank you. If any question from our audience,
One question.
Yes, sir.
please.
Actually, I saw X-ray there. The articular surface is not reduced. How do you plan to reduce all your X-rays?
So usually the selection of patients is type 2A, type 2B. So if it is more communicated, we are not going to select the patient as a criteria.
So it is on the table decision whether if it is reducible, then you put a X-fix. You can go ahead with KYs and finish it up.
No, sir. Pre-op will take the CT and we see the fracture extending to the intraarticular.
And one case I think on the poster that you have put says it was a very simple fracture where 2 KYs would have gone. When you put a KY, there's a paper by Sampath Dumre Patil where you transfix it through the talus to the calcaneum. The articular surface is also intact. Only 2 KYs crisscross. It reduces. The paper is by Sampath Dumre Patil.
So I think with this calculator fixator, we can make the patient mobilize early by around 2 weeks.
I don't think so. I think if you make the patient mobilize, then the small pieces will get sunk and your articular surfaces will not be intact.
Too communicated.
You can't do that. And if suppose a medial burst is there, then I think this one will not work because here you don't open it. There's no sinus assay approach where you do.
Yes.
And how would you address the medial fragments if they are there?
I see.
Because here, if it is only 3 fragments, then you can go ahead with this. If it's going to be 4 or 5 fragments, it is difficult. I think so.
If it is more communicated, we
Okay, thank you. Thanks
Thank
for
you,
that.
thank you.
And now I would like to acknowledge all my professors for allowing me to present all their cases. Osteomyelitis of femur is not uncommon and presents with challenging therapeutic and reconstructive problems. The goal of the surgery in the treatment of sequence of a chronic osteomyelitis is to remove all non-viable tissue, leaving only the viable bone. Considering the annual incidence of osteomyelitis in children is to be 13 per lakh population. So coming to the material and methods, the mean age was around 16 years and we have 3 cases and all of them were certainly with a type 4, that is diffuse osteomyelitis, and the mode of transmission was, one case was post-traumatic and rest of the 2 cases were hematological. And all the cases, the average was 2 years of suffering from their side and 2 of them presented with a pathological fracture of the femur. Presentation was with a discharging sinus, on and off fever, and all the cases had knee stiffness with very minimal range of motions. And one case, because of extensive debridement, we had to compensate it with cement beads. And in another case, it presented to us with a failed fibular bone grafting. Coming to the procedure, after application of femur frame, sequestrectomy and saucerization was planned, and considering the defect, cement bead placement was then planned. And on the other side, if the defect is well manageable, then vancomycin powder would have been sufficient enough for local antibiotic delivery. And all the cases were started on weight bearing from day 2. And once after 4 weeks, cement bead is removed, the full weight bearing was allowed for the case. And serial X-rays were done at 4, 10, and 16 weeks. And coming to the assessment tools, at a regular follow-up, we followed them with infection markers, SF36 and EQ5D5L to know the difference of quality of life that we will be observing. And at the same time, look for hypertrophy and consolidation, and at the end, plan for removal. The results were, the mean time was 17 days of hospitalization and blood markers reached normal limits within 4 weeks. And coming to EQ5D5L, the average score, which was around 50, or which was around 88, it reduced to around 50, which summarizes that a lot of agony was that we were able to compensate with because of use of Elizaro frame. And the similar is SF36 questionnaire, where the main follow-up was done with considering only physical, emotional, and social functional outcome, and it has shown significant difference considering pre-op to the post-op values. In the review of literature, only the one article was justifiable. That was with Fodor et al., who concludes that extensive bone debridement and prophylactic external fixation associated with antibiotic therapy, and it is an acceptable treatment protocol for the management of chronic osteomyelitis. And at the same time, Simpson et al. Recommends a resection margin of at least 5 mm within into the healthy bone. A similar concept was adopted for our cases, and as the leg was already on an Elizarov frame, extensive debridement was carried out without any concern for a pathological fracture. And coming to the conclusion or the findings through all these cases was Elizarov frame is an ideal method for salvaging the limb in chronic osteomyelitis. Extensive debridement into the margins of the normal bone is the key to eliminate the infection. And stage protocol is reliable and safe in providing successful simultaneous reconstruction for bone and soft tissue defects in chronic osteomyelitis cases. And it also facilitates early rehabilitation. Presenting a case of 17 years male with chronic osteomyelitis of the femur and discharging sinus and for a duration of 2 years. Initial X-ray shows a large sequestrum on the anterior medial side and even on the lateral view we can find it out. On table, the black arrow mark shows a large anteromedial sequestrum with multiple cloacal opening, and the next image showing multiple pieces of sequestra with the largest measuring up to 8 centimeters. This was an immediate follow-up X-ray, and the patient was started on weight bearing on the day 2. As we can see from the day 2, the patient starts to weight bear, and in the next X-ray, the follow-up, we can make it out that there has been a hypertrophy just because of the weight bearing, as we can make it out in the AP as well as in the lateral side, and canalization was also seen. Second case, 17 years male with type 3B open fracture where a large fragment was put in and operated somewhere else. He presented to us with a very stiff knee and a large sequestrum fragment. Whole of the sequestrum was taken out and it is filled with the bone cement, antibiotic impregnated bone cement. And after frame removal, there was a large defect gap, so the frame couldn't be the frame couldn't be removed at this point. So we continued on a weight bearing, and early RM was also started in this case as there was a tibial frame extension was there. As we can see at the 6 months follow-up, there has been a building up of hypertrophies seen on the AP and lateral view, but still further follow-up is required for this case, and the patient is very comfortable after the tibial frame removal. It was done at 4 weeks. And going to the next case, case 3, 19 years male with the previously pathologic fracture with the failed bone grafting, and the presentation was a very purulent pus with MRSA and along with endocrinopathy. And we operated with the excision, and even after complete docking, we were not able to eliminate the infection completely, but the patient's well-being, considering that there has been a significant improvement. So, coming to summarization, sir, the femur osteomyelitis case is difficult to eliminate, but the use of Elizarov will facilitate in early rehabilitation and immediate weight bearing.
Thank you, Doctor. Is there any question from audience? No? Then next.
The outcome of Elizarov fixation in recalcitrant infected tibial non-unit, a prospective study. My guide is Dr. Harshad M. Shah, sir. The non-union has been classified based on the Drawer et al. Classification, and the infected non-union of long bones is a problem in developing countries where the non-union may complicate into persistent infection, deformity, shortening, bone loss, joint stiffness, and disability. In case of non-union and infection, patients may require conventional treatments such as extensive debridements, coverage of soft tissues, flaps, antibiotic bead packing, tibiofibular osteosynthesis, and free tissue transfers. And also, secondary procedures may be required, which lead to multiple surgeries and scarring, and which interfere with the optimal limb function. Whereas Elizarov method addresses all the above problems simultaneously, and the stability of the fixation allows weight bearing and ambulation. Along with that, progressive bone histogenesis following corticotomy and bone transplant helps in filling the bone gaps. Methods include there have been studied on 22 patients, and the average age was 37.2, duration of study of 3-year period, and the initial diagnosis was based on GX classification, in which most of them were type 3, and one patient had closed fractures, and the site of non-union were in 12 in distal 1/3, and the limb shortening was 3 to 11 centimeters, and the bone gap was 2 to 9 centimeters. And most of the patients were referred at a mean time after fracture of 7.8 months. Then follow-up X-rays were done at 3 weeks and 4 weeks interval thereafter until fracture union. Results: all patients had limb edema, ankle equinus deformity, and ankle subtalar and knee joint stiffness. Fracture union was achieved in 18 patients without bone grafting, and 4 patients needed bone grafting. Deformity correction in sagittal plane was less satisfactory compared to the coronal plane, and the problems encountered were most patients had pin tract infections, wire breakage, and chronic osteomyelitis. The results were based on Asami criteria. Bone results of 8 patients had good union, and in functional results, 10 patients had poor union. And bone transport, external bone transport was done in 13 patients, and 9 patients had internal bone transport. This is the first case with fixator at 8 months, and the follow-up X-ray at 12 months, and the clinical photograph. The second case, the follow-up X-ray at 8 months and after fixator removal. The third one, in which the patient had preoperative X-ray with plates and with fixator in situ at 100 days. The fourth case, the preoperative X-ray and at 6 months follow-up. In developing countries like India, risk of RTA is more high due to long distance travel, and patients are more often young and bread earners. Most patients change to sedentary lifestyle and less amount of work due to the fixator. In this study observation, patient tolerated docking well up to 5 centimeters, and if more than 5 centimeters, poor results were achieved. And many of the patients were happy that an amputation was avoided, but at a high price. Patient problems included: patient had earlier 1 or more surgical procedures in which they had loss of working hours, and they had to change their lifestyle and job. And surgeon problems included accident due to malalignment and delaying treatment by 6 months, chronic infections, need for higher antibiotics, multiple surgeries. Other studies also showed the same, in which patient had depression which needed multiple counseling. Limitations included the time and resource, intensive nature of the treatment, difficulties of prolonged fixator use, and potential major and minor complications. Conclusion: the treatment of infected non-union of tibia with iliceral fixation is effective, but it is highly individualized, and early transfer to specialized unit and patient selection are more important, along with emotional, financial, and social support.
Thank you, Dr. Gowda, for being in time. One small question is here. Are you comparing this union with other procedures? This Elizaro procedure with other procedures? Have you any comparison? If there is no any option, then only you go for Elizaro. So I think that this type of problems happen with Elizaro. This mental problem and social problem. Okay, it's nice to enter. But one comment is there. Your paper is having very red background. So next time, if you prepare paper, simple background is better than red background. That's thank you.
I'm Dr. J. Saran, and I'm from Rami Medical College, and I'll be speaking about analysis of results of huge segment bone loss of tibia treated with Elisa external fixate in Indian population. It's a prospective retrospective study. Introduction: incidence of tibia fractures in the world population occurs over 20 per 1 lakh population, and they can broadly be classified based on the topography, that's proximal, shaft, and distal, based on the type of injury, open and close, open being more common, and mechanism of injury, high energy and low energy trauma. And tibia fractures have a high risk of going into non-union or malunion due to its fragile blood supply. So in a study done by William et al., he has observed that in spite of doing intermediate nailing, 37% of them had gone into malunion. And similar study has been done by Mundi, where it was 13% of his cases have gone into non-union. So main goals of treatment of complex tibia fractures should include maintaining normal length and alignment, minimizing soft tissue damage, preserving circulation, and lastly providing mechanical environment for bone healing. So when you think about bone transport, you have 3 modalities: monolateral external fixator,
which can be used with higher chances of pin-track site infections. If there's another modality, intermediate nailing, but here diaphragm cortex blood supply is compromised because of the reaming. Hence, Elisa external fixator is the choice here, and this is my study based on which we do the radiographic and functional assessment post-op. So the materials and methods, study period was for 6 years. Setting was in Ramay Hospital itself. Study design was retrospective and prospective. And inclusion criteria mainly included 80 to 65 age group and bone loss of greater than 5 centimeters at present, and failed segmental bone loss by other treatment modalities. Exclusion mainly the ipsilateral bone defects are excluded, polytrauma, comorbid conditions like thyroid and type 2 diabetes. Method of data collection: the pre-op assessment of the bone defect was measured by IPAC software, and the functionality was assessed by 3 scoring systems. One is the Asamicon criteria, Knee Society score, and St. Pierre Anchor scoring system. My sample size is 20. So the planning. So intra planning, what we had done was first pre-op, we evaluate the X-ray, and we decide the amount of bone to be second, so amount of bone to be excised. And based on that, we divide the entire bone into approximate 20 centimeters and distal 10 centimeters. And we prepare a 4-ring construct, proximal being a 5-with ring, to allow knee ROM. Then we go ahead with freshening of the edges, medullary reaming, acute docking, and application of the laser frame. So this frame is pre-made, pre-op, and then sent for autoclave. Then cross K variant for tibial docking with the fibular osteotomy, and then corticotomy is done with the length lengthening. And we had done corticotomy with the jiggly saw here, as you can see. And this is the pre-op construct. And after removal of the bone segment, the tibia size has been, the loss has been measured here. So the removal of construct, we have basically 3 criteria here. One is there are unit between 3 to 4 cortices. One function criteria to check if there is a pain-free limb, and interop criteria to see once the construct is removed if there is any abnormal mobility in the AP or medial lateral directions. We come to results. Generally, out of 20 patients you have taken, all of them were male, and mean age group was between 34 plus or minus 10 years. Right tibia was more affected than left tibia, which was observed. So most common mode of injury was RTA, and the most presentation was open. And also first contact treatment was most commonly done was an AOX6 application. So intra, what we had done, we had gone ahead with monofocal lengthening in most of our 90%, that's 18 patients. Fibrectomy was done in 12 patients, that's about 60%. And soft tissue procedures, most of them had not required, but in some cases they had used a fasciocutaneous flap and the fasciocutaneous flap along with the split skin grafting. And additional procedures which were done was they had used an autograft for 7 of our patients. And accordion method, most of them did not require, but 5 patients had required, for which we had done twice and thrice. This is statistically significant because p-value is coming up to 0.027. Duration present majority was between 1 to 2 years. Number of surgeries are up to 6 times majority. And liminal discrepancy came to up to 1 to 2 centimeters. And once you come down to the scoring, Assamese scoring, you had seen 13 of our patients, 65% had good Assamese score. Knee Society scoring system came up to 60%, that is excellent. And St. Pierre scoring came up to fair, that's 17. Main challenges that we had encountered, most of them didn't have any complications per se, but one of the major complications we had seen was hampered ankle ROL, along with delayed union and docking site because of end sclerosis, docking alignment, soft tissue imagination, and larger bone defects. So, presenting 2 cases. One case which you have seen here is a 32-year-old male who had an RTA, was diagnosed with tibia mid-shaft with proximal tibia fracture. Initially, had done plating for the shaft along with CC screw fixation for the proximal tibia. Within 4 months, there was an infected site along with the draining sinus, for which we had to remove the entire implant and then apply an Elisarov. And once we had debrided that infected segment, it was about 149 mm. So we had done serial follow-ups with lengthening, and by the end of 2 years and 7 months, we can see the bone regenerates come up to 170 mm. This is monofocal. Knee ROM was completely not hampered at all, and ankle ROM was also within the normal levels. And Assamese score was good, and ES Society was excellent, NP was fair. Similar case 2, 26-year-old male RTA. He had both bone open fracture, type 3B. Initially, X-fix was put, but there was no callus formation between the bone segment. So we had removed the X-fix and then gone ahead with Elisarov. And here we had done bifocal lengthening. And proximal distal region was present. So initially gap was 164 mm, but at the end of 2 years and 7 months, we could see that bone defect was filled. And the proximal distal region together add up to 181 mm. So here also the function was present at the knee. So conclusion says, Elisa external fixate is a better choice of treatment of complex fractures of tibia as it interferes minimally with blood supply. Weight and joint mobilization can be started early with fixate density.
maintains mechanical alignment of the limb, and provides three-dimensional stability. It has proved to be equally effective as that of internal fixation in treatment of periarticular fractures and induces axial micromotion at the fracture site and can accelerate fracture healing. So these are my references. Thank you.
Introduction. Any question from audience? If there is no question, then please. Yeah.
Hello everyone, I am Dr. Udit Kumar Biswal from Bhubaneswar. I am primarily doing trauma and arthroplasty, and out of my own interest, I have started doing Ilizaro from last 2 years. I had no formal training. The following cases. Is the most reliable method of treatment for infected non-unions, especially where we have bone loss. It is especially bone loss of 4 cm or more. Bone transport is the preferred method instead of acute docking. And duration on frame is actually long, and it's roughly equal to the bone gap in centimeters, some cases even double. So this long duration of treatment is fraught with a lot of complications which we encountered, especially if you are untrained, such as pin site infections, translation or angulation at docking site, over or under distraction by the patient, skin invagination very common, ankle deformity, knee subluxation, and neurovascular compromise. Close follow-up with patient is required because patient himself or herself is doing 70% of the work, like distraction and pin site care, and ensure patient education and psychosocial counseling because it is a long duration of treatment. So period of inclusion was between April 2022 to March 2023 in a single medical college hospital, and diagnosed cases of infected non-union undergoing Ilizaro treatment were included, and those previously treated by Ilizaro or multiple fractures and bilateral fractures were excluded. So we got about 12 patients who completed follow-up till frame removal, and all the patients were operated by 2 stages mostly, because stage 1 infected implant removal, sequestectomy and thorough debridement was done, followed by in the second stage we have done infected implant removal and Ilizaro application we have done. In some patients where we are anticipating any soft tissue reconstruction procedure which will be difficult through the Ilizaro frame, we have applied first external fixator, otherwise all the patients we have applied Ilizaro fixator. And in the second stage, after some amount of wound healing, we have done corticotomy and started transport at a regular rate. And after frame removal, we have done BTP casting for 1 month for all patients. So mean age was 31.3, 11 males and 1 female. Mean duration from initial trauma was 7.2 months, and all patients had history of discharging sinus with infected implants in situ. 3 patients having undergone flap or skin grafting in the fracture area. Most common organism which we found from intra-op cultures was Pseudomonas followed by Staphylococcus. Mean bone loss of 9.6 centimeters. 4 patients, as I told, we had done staged external fixation first, then Ilizaro frame to allow for soft tissue reconstruction. For bone transport, we have applied this construct with 4 rods connecting all the rings, and except one child where we have used 3 rings, and we have used foot frame in 2 patients. Corticotomy's mean duration from frame application to corticotomy was 13.23 days, and the location was distal 5, proximal 6, and dual 1. And pattern of corticotomy according to the classification by Malaysian Orthopedic Journal, type 1, the strict clean cut transverse with no comminution, that was 5 patients, with some comminution 6 patients, and with a butterfly fragment in 2 patients. And emphasis on mobilization was given for all patients, and toe touch weight bearing was allowed from day 1 with knee and ankle mobilization. 3 patients had equinus contracture pre-existing, and 1 of them required percutaneous TA release. So these are some challenges which I faced during bone transport. 27-year-old male, he presented to us 1 year post-injury. Somewhere plate had been applied and intervening bone fragments had been removed, and plate was exposed. He had a very thin leg with very minimal soft tissue cover anteriorly. So I removed the infected implant, debrided, and first stage I applied fixator. And there was a gap of 3 months between X-Fix and Ilizaro because flap was not possible due to poor soft tissue. So waited for secondary healing. Then applied fixator, started bone transport proximally, but there was severe pain and bone fragment was protruding out of the leg. So stopped the proximal transport and started it from distal. Again, distal corticotomy was done and transport, and huge skin invagination developed after 6 weeks of distal to proximal transport, which was treated by open docking and bone grafting, followed by lengthening. So after that it healed. This is the second patient. 7 months post-injury with infected implants. We started same from distal to proximal corticotomy. After about 6 weeks, he developed this equinovirus deformity, and after about 8 weeks, it was well established and it was not correctable. So I called him back and put a foot frame correcting all the deformity. And there was some angulation and translation for him after about 12 weeks, but at the time of docking, it corrected by itself, and he went on to achieve full wet bearing. Inside infection, 50% had some amount of inside infection, but no major. And angulation and translation seen in 8 cases, 6 of which required open docking. All patients united well. Mean time to union was 6.7 months. 6 patients required open docking for translation or invagination. So final outcomes: 6 patients inside infection, stretch pain 4 patients, skin invagination 4 patients. 1 patient got a refracture, which are planned for intramedullary nailing later. Otherwise, there were no other complications. Thank you.
Thank you, Dr. Now may I call Dr. Ibrahim?
Talking the bill. I am presenting the topic. This is a rare case of inline adenoma of tibia managed by limb salvage surgery using long segment Elizaro bone transport. This adenoma is a primary low-grade malignant tumor of epithelial origin. It is predominantly localized in the mid tibial trapezius. There is a 0.1-0.5% of all primary bone tumors. It occurs in the second and third decades. Ewing's-like adenoma is a rare variant with clinical presentation, radiology, and histology of adenoma with genotype suggestive of an Ewing sarcoma. Here we present a rare case of Ewing-like adenoma treated with a limb salvage surgery using a 3-step Elizaro technique with good result. We are focusing the case report is drawn attention to an extremely rare variant of adenoma and the outcome of our treatment method. Here is the case report. It's a 39-year-old lady presented with swelling over the right lower leg interiorly noticed 8 years ago. Is gradually increasing the size associated with over the past 6 months. Associated with pain on walking for more than 10 meters, there is no history of trauma and infection. Local examination, the size of 15 to 6 into 3 cm hot swelling continues with the anterior border of the right tibia. There is no localized of temperature or tenderness. The overlying skin is featured. This is an X-ray showing AP and lateral view. This is an eccentric, expansile and diffuse lighting lesion in the distal of the tibia. The anterolateral cortical break is seen. There is some marginal sclerosis in all the X-rays. Next, we have further evaluation by blood investigation, MRI, specs, and HBR and tumor markers. In MRI, there is an irregular eccentric expansile lighting cortical lesion in the anterior cortex of the tibia with a narrow zone of a transitional. The extension in the intramuscular and subcutaneous plane and separate lesion was noticed in the lower third of the right fibular diaphysis. This is a lesion distal tibia isointensity T1W1 and hyperintensity T2W2. There is the fish is positive. There is a 22q12 gene rearrangement is positive. The SPECT CT is showing there is a significant cortical destruction and medullary involvement. HBR and ILC showing that the true-cut biopsy show the high-grade spindle shape cell neoplasm suggestion of adenoma with areas of an round blue cell crust. And there is a CK and P1253 is positive. On this, we are advice of an oncosurgeon. He is tell about the preoperative chemotherapy and followed by limb salvage and wide excision of tumor. This is our treatment plan. The first stage is tumor resection, Elizaro application, cement spacer, and soft tissue cover. Second stage, there is a cement space removal, corticotomy, and transport. And third stage is bone grafting at docking site. Then tumor resection, including the soft tissue. And the bond defect after resection, there is a cement spacer based on the defect. So wound closure problem, we are doing an XST after that. And after this resection, we have sent the HBR, so there is an differentiated adenoma and also the positivity of CK53. Second stage is a space removal and corticotomy done. This is the photograph. Then after corticotomy after 14 days of the distraction. Third stage, the bone grafting at the docking site. After bone grafting action, there's the post docking within a bone graft, the yellow shape, then regenerate ossification in the red margin. And before this, just removal of Elizaro. This is a fully united post Elizaro removal. So after that, we are doing the cast base applied and started unassisted weight bearing. This is the video of the gauge. The discussion, adenoma can be classified into classical and dedifferentiated. Differentiated varieties include Ewing-like adamantioma-like Ewing's, and osteofibrous dysplasia. The Ewing's-like adamantioma is the least common variant of this adamantioma. Reconstruction after a wide incision of such tumors is difficult, primarily because of a relative decreased vascularity of the distal tibia and its anatomical proximity to the neurovascular bundle and the tendons. Its conclusion: the controversy as to what constitutes the difference between the adamantioma like Ewing's and Ewing's-like adamantioma persists despite technological advances. The appropriate treatment protocol remains to be established. The Elizaro three-step techniques provide a feasible alternative to amputation while circumventing the difficulty of a large bone reconstruction in the distal tibia. It's the take-home message. Ewing-like adenoma is a rare entity, requires clinical, radiological, and pathological correlation for diagnosis. Use of Elizaro bone transport is a viable alternative to amputation if the wide excision with clear margin was achieved. Management protocol for lesser non-variant are not well established, and there is still controversy regarding efficacy of the chemotherapy in this case. Thank you, sir.
Nice, Dr. Ibrahim. Do you prefer to give him a radiotherapy, chemotherapy, or radiotherapy? Before surgery?
Before surgery, pre-operative we have done.
Pardon, please.
Pre-operative we have done chemotherapy. After that,
Radiotherapy also, Ewing's
no, chemotherapy.
chemotherapy. Okay. That's good paper. So, any food construct you have added in your leave? Right? Food construct? No. Okay. Fine. So,
Myself, Dr. Kuldeep Kamar, Elizaro limb reconstruction surgeon, Rajkot, in the state of Gujarat. I'll be presenting the study. My aim of the study is to evaluate the functional and bony outcome of a mid-segment tibial bone loss, either primary due to trauma or secondary due to the infection followed by plating or nailing. We treated with debridement Elizaro fixator as usual, but with the dual corticotomy in cases of mid-segment defect and transport versus the single corticotomy. So I retrospectively analyzed 20 patients who were managed with Elizaro ring fixator from 2020 January to March 2022 at Rajkot, and all the surgery were performed by me. Among 20 patients, there are 10 patients which were having mid-segment tibial loss, 10 having the loss geographically more in the middle and lower segment. 20 patients all the patients underwent ring fixator. 10 had only proximal tibia corticotomy, but 10 had proximal as well as distal tibia corticotomy. All the patients were operated under spinal anesthesia. Adequate debridement ring fixator was applied and using a drill technique and not the open technique. During that period, in case of infection, we have given 2 weeks of IV antibiotic and additional 4 weeks of oral antibiotic given. Distraction started on post of 8th day after transport completed. In all cases, we do open docking and bone grafting, except in one cases where the centimeter of gap was 4 centimeter only, so didn't went for the open docking. Patient followed monthly till radiological review checked for the gait and loosening before the removal, and then after removal, 3 months of walking patellar tendon bearing brace have applied in all the cases. So this is dual corticotomy case, was operated with nailing followed by infection followed by external fixator and a flap. So I resected the mid segment, 10 centimeter of round gap. I did initially I put in a cement spacer, and then after 3 weeks I applied I did a corticotomy proximally as well as distally. As it has come down, we had open and dock the open docking was done, and 10 months follow frame removed and brace applied. Okay. So patient is walking. Another example for taking a single corticotomy case. As I said, that 10 cases where the fragments topographically they were distal or the medial bone loss, where single corticotomy was done. Here the open injury was treated initially with the fixator only, then in the same seating fixator, and the split thickness skin grafting was done for the raw area, and the gap was around 4 centimeter. I deliberately cut the bone ends to make the fracture transverse. Actually, the gap is not that much more, but to make the good contact while after the transport, I made it a more gap, around 12 centimeter of gap. And then once it come down, I had done a docking and bone grafting. That is 17 month, that is 18-month follow-up. That is the invaginated skin, undeliberate complication we have, but patient is fine. So this is the demographics. The 10 patient underwent the bifocal corticotomy. 10 had a monofocal corticotomy. Mean age was around 26, 32 in that cases. 8 were the male, 2 is the female in bifocal group. 6 were infected in case of bifocal. 7 were infected in monofocal group. And 4 had primary bone loss due to the trauma, and 3 had primary bone loss. Mean gap was around 8 centimeter in both the group, and mean duration of fixator time 9.1 months, and there 13.3 months. Duration of follow-up is up to 2 years, and previously done surgery is nail plate and external fixator. The things I had come across over here is the fixator time and the healing index. It is 1.15 month per centimeter in case of dual corticotomy, and 1.5 months in case of a single corticotomy. And the results were assessed on the Assamicon scoring system. The excellent result in both the group have been shown by up to 80%, a good result up to 10%, and more in single frame it is 20%, and fair in bifocal group. But when I see the functional outcome and the Assamicon score, it went up to 90% in bifocal, 80% in monofocal. 10 had a good result, and 2 patients had a good outcome. No patient had poor outcome. That is what I have described here. 12 patients among 20 patients suffered pin site infection. 10 were treated with the change of the 10 were treated with just 5 days oral antibiotic course that we have to do in 1 or 2 times all the duration. 2 patients need to change the wire. 1 patient in bifocal group, I would say 2 dual corticotomy, where he had equinus deformity around 10 degrees. I applied a ring, heel ring, did a fractional TL lengthening, did a distraction, still it did not get corrected. That is the true complication in dual corticotomy case, I would say. 1 patient in bifocal developed temporary knee flexion deformity because the forces are higher in the dual when we are doing tendon transport. But it settled with fixed physiotherapy. In few cases, we stopped the distraction for a few period of time and then allowed after 2 or 3 days of break, or we say go for the 5 days of distraction, keep 2 days of break, get the physiotherapy aggressive, and that settles. So fixator time to get 1 centimeter heel in bifocal is comparable to that of monofocal in my group. That is 1.15 month per centimeter to 1.5 months per centimeter in monofocal group. Many studies have been done in PRAS. One of is our senior fellow Ajit, who has also shown the fixator index is 1.71, and another is 1.5 month. That is international study by Frogaman and Austin. So the fixator index is also comparable to the national and international study. But when considered the bifocal group, I could come across that 1.15 month per centimeter is lower than that of monofocal group, and with fewer complication to its outcome. So Elizarov fixator has been used extensively for the gap non-union of tibia, but when we come to conclusion that there is a mid-shaft defect, and whenever bifocal lengthening could be done and lengthening and is done should be considered, which reduces the fixator time without ongoing for the secondary surgery like plating and nailing, because there will be again 15 to 20% chances of reinfection if we do the plating and nailing to reduce the fixator time. Thank you, sir.
Okay, nice presentation. Just you are having a good experience with Elizaro, I think. Just share some experience here. If patient is having tobacco or alcohol regularly, Is there any change in the speed of the lengthening?
If
1
the-
millimeter
if the
a day or
patient-
half millimeter a day?
Nah, sure. If the patient is tobacco and smoker,
Yeah.
more specifically smokers, they are the headache to us.
Yeah.
Regenerate rate is so poor. Almost all patient with the smoker category and
And that too, malnourished patient.
yeah.
Whose muscle bulk is less and
We go with
is less.
slower distraction rate, 0.5 mm per day. And in distally always, because there is a less bone mark, soft tissues in the distal tibia, we go with 0.75 only.
Okay.
Even if that is not providing us some callus at 1 month of distraction or 2 months of distraction, we will put in we will break it, or we may compress rather than distract, and then again start distraction, sir. And smoker, almost all cases I had to do regenerate bone grafting. Not only the fracture side bone grafting, but the new bone formation side also we have to do bone grafting. But that heals well because there is some periosteal sleeve at the tube has formed. In the
Only
region.
one thing I have suggestion.
Yes, sir.
You have done everything.
Yes, sir.
But when you make it a transverse
Yeah.
and made a gap,
Yeah.
there was a good number of gap
Yeah.
for starting the case.
Yeah.
So in my experience,
Yes.
I used to do shortening in a later period, in second stage surgery, not in the primary.
Okay, sir.
Before talking,
Okay.
1 month or 2 months.
Okay.
This is just
Small.
small suggestion.
That can also be. That can also be. But the thing is, sometimes patients count the number. I had been 4 times operated, I had been 5 times.
मैं नॉर्मली
Yes.
नंबर ऑफ सर्जरी से नहीं डरता हूँ. मैं बोलता हूँ पेशेंट को
हाँ.
8 बार लगेगा, वो 10 बार भी हो सकते हैं, 12 बार भी हो सकते
हाँ, सही है सर.
हैं. कोई दिक्कत नहीं. थोड़ा भी प्रॉब्लम हो तो ले ओटी में स्पाइनल में तो करना है.
Yes.
बट है ना.
Hey, good sir.
चांस
You are-
देना चाहिए.
you are-
चांस देना चाहिए कि कई बार टॉकिंग होगी वो लेंथ रिड्यूस हो जाता है.
Yeah. True, sir. Thank you, sir.
Otherwise nice.
Thank you, sir.